Community-acquired pneumonia. Key points. Community-acquired pneumonia, CAP, can be diagnosed clinically when there are signs of a lower respiratory tract infection and wheezing syndromes have been ruled out. CXR is not required for routine diagnosis or management, unless severe or complicated pneumonia is suspected. Blood tests and microbiological investigations are not recommended for routine use in the diagnosis and management of CAP. For non-severe pneumonia, high-dose oral amoxicillin is recommended, even for inpatient use. Blank. Background. Pneumonia can be defined clinically as the presence of fever, cough, and tachypnea at rest, and retractions in younger children, when clinical wheezing syndromes have been ruled out. Complicated pneumonia occurs when there is a complication such as parapneumonic effusion, empyema, lung abscess, necrotizing pneumonia. Assessment. History. Fever, fast breathing at rest, cough, increased work of breathing/respiratory distress, apnoea. Examination. Appears lethargic/unwell, hypoxemia, tachypnea, chest wall indrawing, retractions, grunting, nasal flaring, crackles and bronchial breathing on auscultation. Absent breath sounds and a dull percussion note suggest a pleural effusion. Assessment of severity. Severe pneumonia should be considered if there are clinical features of pneumonia and one or more of blank. Severe hypoxemia or cyanosis, marked tachycardia, altered mental state, blank. Management. Investigations, including CXR, recommended routinely for investigations, including CXR, are not recommended routinely for CAP, particularly in those with mild disease who are expected to be managed as an outpatient. Chest X-ray, post-anterior view, recommended for children who require admission or if severe or complicated pneumonia is suspected. Consider repeating if the child fails to clinically improve after 48-72 hours of appropriate antibiotic therapy. Follow-up CXR is not required for those who recover uneventfully. Follow-up CXR is recommended after 4-6 weeks for complicated pneumonia. Persistent signs. Recurrent pneumonia involving the same lobe or if initial suspicion of a chest mass, anatomical abnormality, or foreign body. Severe or complicated pneumonia. UEC for children receiving intravenous fluids, FBE and blood film. Microbiological investigations. Blood culture has a low yield and is more likely to be positive if empyema is present or in a child with severe/complicated pneumonia. Testing for influenza, nasal swab or ASPI rate for PCR. Avoid testing for other viral pathogens, will not change management. Acute phase reactants, particularly CRP and procalcitonin, cannot distinguish between a viral or bacterial cause nor indicate severity. Consider testing to monitor progress. Treatment. Admission to hospital is required for oxygenation, fluid therapy, or moderate to severe work of breathing. Check oxygen saturations and provide supplemental oxygen if saturations are and LT 90%. Blank. To avoid fluid, advice status. Advice regarding antibiotic management is summarized in the algorithm below. High-dose oral amoxicillin is considered as effective. As for benzyl penicillin, most children can be managed with oral antibiotics. Blank. Child with suspected pneumonia. Penicillin hypersensitivity. Non-beta-lactam antibiotic alternatives include azithromycin 10 mg per kilogram, max 500 mg, oral daily instead of oral amoxicillin, or doxycycline for 8-18 years, 2 mg per kilogram, maximum 100 mg, oral twice daily on day 1, then 2 mg per kilogram, maximum 100 mg, once daily, instead of oral amoxicillin. Use rounded doses. And LT 26 kg, 50 mg, 26 kg to 35 kg, 75 mg, and GT 35 kg, 100 mg. Doxycycline, not been associated with tooth discoloration, enamel hypoplasia, or bone deposition, even in children younger than 8 years. However, use is limited by the lack of a suitable formulation. Blank. 4, blank. 4, blank. Atypical pneumonia. Testing for causes of atypical pneumonia, including mycoplasma, rarely influences management, as it does not differentiate infection from asymptomatic carriage. There is no proven benefit from treatment with macrolides alone or in combination with beta-lactams in children with suspected or confirmed atypical pneumonia. The only exception in practice is in cases of severe pneumonia azithromycin may be considered, as the perceived benefit is greater. Consider consultation with local pediatric team when fulfills criteria for hospital admission, outpatient therapy fails. Consider transfer when severe or complicated pneumonia, comorbidities such as cardiac disease, chronic respiratory disease, immune deficiency, or suppression are present. Child requiring care above the level of comfort of the local hospital. Child has an O. Requirement is FiO2 of and GT 50%. Blank. Blank. Consider discharge when child is maintaining adequate oxygenation and oral intake. Note: children managed as outpatients should have medical review in 24-48 HRS.